I think really leadership is tied into effective teaching. And it's kind of like patient care. When there's a belief that you're going to be led in the right direction, then it just becomes a matter of keeping our minds open and learning from one another. So I think that those people who are good mentors or teachers tend to be good leaders as well.
All right, welcome to Hands On, Hands Off. I'm your host today, Moyo Tillery. And for this episode, I am joined by someone I respect deeply and have had the pleasure of working with for a couple of years now, Dr. Ron Shank. Ron is a professor, he's a mentor, a thought leader in OMPT and mechanical diagnosis. Um, Today, we're talking about bridging the gap between the evolution of OMPT and directional preference. And if you followed Ron's work, you know that he's been involved in both worlds, so to speak, or are they the same worlds? That's for us to get into today. Welcome, Ron. Please tell us a little bit about yourself, and we'll get the conversation going.
Well, thanks, Mo. Thanks for having me. I'm a graduate of Ithaca College Physical Therapy program. And then I went on to do a residency in Gulfport, Mississippi with Mike Rogers, who's one of the founding members of AOMPT. Later on, I became McKenzie certified and earned my PhD and became a fellow in AAOMPT. And from the mid-90s on, I've tried to bridge the two schools of thought. And I really do think there's a place for directional preference in the schema that we use for examination and intervention for people with musculoskeletal disorders.
Yeah, no, that's great, Ron. Thank you. It's such a pleasure to have you. I'm glad we get this time to chat about something that I think has been on, maybe certain people's minds as far as bridging this gap in these two very clinically applicable and appropriate, right? Once you figure out which patient is appropriate for what technique or mix of techniques. I want to know a little bit. I think we can take it back, Ron, if you're okay with that. Let's start with maybe your personal journey. You've mentioned OMPT giants like Mike Rogers and the late Dick Earhart in your own training.
Yeah.
You've also had numerous publications on directional preference. Can you walk us through maybe how you first encountered directional preference and perhaps how your understanding of directional preference has evolved?
Sure. So back when I was at Ithaca, one of our musculoskeletal professors was Robert Sprague, and Bob Sprague is well known to people in AOMPT. Bob is a founding member of MAPS, Maitland Seminars, but he also taught with Rob McKenzie himself early on when Rob McKenzie first came upon his directional preference approach. And so Bob kind of integrated the two back when I was an undergrad in physical therapy. And it was probably a little too much to handle for someone who's not seen patients yet. And it didn't begin to make sense until I started working at a hospital in Buffalo, New York, and seeing outpatients and began to apply some of that. But to further that thinking in that area, I took a McKenzie A course, a lumbar course. And around that time, I was a clinical instructor, and one of our students came into the clinic and said, you ought to think about this residency program they have. I just spent 6 weeks in, and it's down in Gulfport, Mississippi. And I said, wow, really? He said, yeah, you worked there for a year for this guy named Mike Rogers. And what he does is he integrates all different schools of thought. So I really do think Mike was a forerunner in combining schools of thought and utilizing what's best for the patient and not necessarily trying to get the patient to fit into your school of thought or your way of thinking. So we were exposed to osteopathic, Maitland, McKenzie, many different approaches for management of people with musculoskeletal disorders. And it wasn't until I returned back to Buffalo and continued to see patients that I thought I maybe wanted to explore that directional preference approach or the McKenzie approach a bit more. So, I pursued certification in that while still studying and practicing manual physical therapy. And I thought, right from the beginning, like Mike had told us, If you have an understanding of many different schools of thought, you can apply them to a fairly high level. You can help
Mhm.
out many more patients because we know not um, every patient's going to respond to one approach. And although we may be biased towards a particular system or approach, and that's good, we know that the reliability of these different systems we have for examination and treatment, not one stands out as being more reliable than another. But what we do know is when you have a system and you
Mhm.
have a way of approaching a patient in a systematic manner, that you tend to have better outcomes than people who just kind of do things without a
Mhm.
treatment-based classification type of approach. And interestingly, that when we were down in Mississippi, Dr. Dick Earhart, also a founding member of AOM, he'd come down to the residency every year and do some teaching. And he was of course a proponent of the treatment-based classification system. So matching that impairment and those functional
Mhm.
limitations to a particular classification, and that fit very well. It was very compatible with MDT, I thought, and also the treatment-based classification approach has a specific exercise category, which is based on centralization. So if patients with peripheral symptoms were found to centralize with extension, they'd be placed in that specific exercise category. So Dick Earhart too taught with Rob McKenzie early on and appreciated some of what he had to offer. But being a chiropractor and a manual physical therapist, a physical therapist, Dick Earhart used a combination of schools of thought as well. So I had a lot of respect and was influenced greatly by that. And the fellowships and residencies that we developed were based on that concept of integrating approaches, using the best
Yes.
features of different approaches to find out what's going to be best for that person sitting in front of you. And
Yeah.
our Damon program required McKenzie A and B courses, the McKenzie Fellowship, which was post diploma. So these were people that reached the highest level of training in MDT, were then exposed to other schools of thought as part of their fellowship
Mm.
training. So we utilize the same clinical instructors and mentors, and we think that that combination of approaches, still giving respect to that person's bias and understanding what's their go-to, but still being open-minded. And I see in our schema of examination, which was developed by Syriacs, active, passive, you know, resistive movements, we can put it after the active movements testing end range. So
Mhm.
prior to testing passive intervertebral motion or single segmental mobility testing, why not explore the potential for a person to find a directional preference through their own volition? So before we would test end range, we test the person's ability to go to end range.
Mm.
People can do it. Some people need assistance in that. And whereas extension may be thought of as, or neck retraction in the upper quarter, thought to be a movement that may produce a centralization of symptoms, there's actually many different loading strategies and directions that may be explored in order to find if that person may centralize or exhibit a directional preference. Um, and I think it may be gaining some traction when we look at patient empowerment. People may be
Yeah.
able to treat themselves and not necessarily be dependent to as great an extent on us. However, people do need hands-on, and those
Mhm.
approaches that foster hands-on training and psychomotor skill development, when they, treat the patients and they encounter that patient, they put their hands on, uh, regardless of the algorithm they follow to determine that intervention, they're doing so in an extremely competent and confident manner, which is then conveyed,
Mhm.
and the patient thinks, well, this person is skilled and knowledgeable, and you're already halfway there then, the
Right.
alliance. Yeah.
And the trust, yeah, the trust is there. Ron, there's so much in what you said, and I think that this is part of, you and I talked about this. This is kind of why I immediately thought about you and talking about something that is foundational to OMPT. You've kind of seen the evolution of how we've gotten here and have spoken to that. And what I'm pulling from a lot of what you said just now, too, is those are the things that we're teaching for those of us in academia, and even clinical teaching, is it's still got to be about the patient, right? Like it still has to be patient focused, and the patient, if you treat the impairments, it almost doesn't matter, maybe what path or what siloed thinking you choose, because you're tailoring it to the patient. And that's really important. A lot of evidence now we know through like the CPGs is a multimodal approach, to intervening for our patients. And I think, I've been guilty of it too. Especially when I first became a fellow, I was like, I want to do all these techniques on everyone. I want to practice, get my skills well, but you may go a year and never have to manipulate a talocrural joint because you just don't have a patient that needs that. So I really have a deep appreciation for the way that you have illustrated, kind of where we were, how you lived where we were, and how you are now living where we are.
Right.
Um, I do want to kind of shift a little bit. You started to go into this a little bit, Ron. Let's shift to OMPT practice, specifically where you've seen it evolve from really hands on, kind of heavily hands on approach, maybe clinician focused approach, to periodically, what I would say now of somewhat of a more hands off approach, while acknowledging the expertise of the manual therapist who needs to put their hands on. Um, Maybe where does directional preference fit in now, as we're sort of bridging these two paradigms where we're occasionally hands on, occasionally hands off? Where's directional preference? What are your thoughts?
Yeah. Well, you said something I think that's pretty profound in that we have to have an examination that's inclusive enough to appreciate a potential impairment. So if
Mm,
we go in and our only tool is to test repeated end range movements, then we're kind of left with that in terms of how we may manage
mm,
the patient. If we omit testing muscle balance, we then lose the opportunity to encourage people to stabilize or utilize exercises that may address their chief impairment. So when we have a thorough examination that may be inclusive of testing repeated end range, I would certainly recommend that. We could put an asterisk toward or at that impairment,
mhm,
and that tends to stand out, that we appreciate maybe the thing that we go after
mm,
initially. And if we don't have a thorough exam, then we're missing out. We're really not doing that patient justice. And it can be done in an efficient manner, provided you have exposure and training in these different approaches. So we're finding that some people are interested in pursuing further training in
mm.
MDT, and we also find that our MDT fellows, McKenzie fellows that are now part of the academy, are learning more from our other colleagues who, are approaching patients a bit differently. And that was really the vision of the founding members of AOMP. They
Mm,
all had their very invested approaches to treating patients, but they had the vision to understand that it wasn't the answer for everyone. And
yeah.
that's the difference between an institute and an academy. So, the academy is comprised of a lot of different institutes and schools of thought, and really, it's very rewarding and exciting to go and learn something new when we go to these conferences and hear research and see um, techniques taught in these breakout sessions that maybe we wouldn't be able to offer our patients without that exposure. So you can pretty much say if you go to a McKenzie conference, you're going to hear about McKenzie. If you go to a Maitland conference, you're going to learn about Maitland, or Maitland seminar, you're going to learn about
Mhm.
Maitland. That's fine. And when you learn something to a very high level and you're able to distinguish signs and symptoms and come up with a classification or a diagnosis, patients are probably going to do very well. And we've had
Correct.
McKenzie fellows go out for mentorship from a Paris fellow, and both learned from one another. And I've been a mentor for people from James Dunning's program and other programs as well, and I've learned and then adopted techniques based on that. So that's really a compliment to those
Mm,
Stanley Paris and Dick Earhart and Mike Rogers and others, Bjorn Svensson, who had that vision way back when.
mm.
And they didn't always agree. I mean,
Sure.
I understand that it was, and I was a member of the board at AOMT at that time. That there's sometimes some very
Some heated discussion.
Heated discussions, thank you, Mo. The heated discussions in regards to how things were being approached, but still they were able to let that go, and it's really for the betterment of the patient then ultimately.
Yes. Yeah, I love that, Ron. And you know that I went through MTI, and Tim and Krzyzewski and Peter Kroon developed that program. And
They were in my
similarly,
program right after me, so
so
yeah,
you basically know what I learned and
I
what
know
they
what you
taught.
know.
Exactly, and a whole lot more. But that's part of what I really appreciate about our community of practice. After going through MTI, which, like you said, is an institute, that's an important distinction that I never thought about, institute versus academy, is getting this mix of techniques and schools of thoughts. And it really deepened my appreciation, I think, to the homage that you paid to the founders of AMT, which is um, the that our outcomes are that much better when we do kind of infuse these different techniques, versus walking in our single silos. And one size fits all treatment has obviously been disproven to be effective in managing patients. I love this community practice for that reason. So now I have to put you on the spot. Before I go into mentorship, because you talked about mentoring different people from different programs, we're going to end on that, Ron, because selfishly, I really want to spend a little bit of time there. But
Hmm.
do you think, Ron, that where we are right now, and what you've seen, what you're seeing, do you think that OMPT and MDT are like finally coming together, or do we still have some work to do? What does that look like? What are your thoughts?
Well, it's moving in that direction, and directional preference I think is kind of a hard concept to argue about in regards
Hmm.
to asking people to move in directions to end range and see if that direction produces a lasting change
Hmm.
in their signs and symptoms. So it isn't just um, a person moves in a certain direction, they feel a decrease in their symptoms. It should be decreased and better or a lasting improvement for it truly to be a directional preference. And originally, Rob McKenzie described it in terms of centralization. So if symptoms were found to move from a more distal to a more central location, then
Right.
that would be directional preference. But that's just one example. It could also be localized pain that decreases and remains decreased, or maybe a baseline that improves. It may be range of motion, or it may be a neural sign that changes and remains improved as a result of moving in a particular direction. So there's been over 50 articles published on centralization. MDT is among the most researched approaches in musculoskeletal practice. And I think part of the reasons one of the reasons it's so researched so extensively is that it seems so simple, but it's
Mm.
not that simple actually. And in a scoping review that was recently published in the Journal of Physical Therapy, there's found to be 111, different definitions in the 10,000 articles that were described. Not
Yeah.
111 different definitions, but there was a quite a bit of discrepancy in how it's defined. So
Yeah.
it's operationally defined as a lasting improvement in a baseline as a result of moving repeatedly or sustaining an
Mm.
end range movement. So the evidence is emerging. It's not fail safe. In a
Sure.
systematic review published by Halliday in Journal of Orthopaedic and Sports Physical Therapy, they found when MDT or McKenzie was operationally defined and the clinicians operated according to that, that those definitions, that MDT did have a greater treatment effect size.
Mm.
When we looked at credentialed therapists or people who've learned this approach in a article published in 2025 by Hanneman and colleagues, they found that those that were trained, had more favorable outcomes in comparison to other approaches,
Yeah.
if they had that training in it. So it's about exposure and paying respect to the evidence in the literature. We have
Yeah.
systematic reviews and meta-analyses and randomized controlled trials that may show the efficacy of a particular approach, but ultimately it boils down to the evidence of the patient. And like you said,
Mhm.
you're able to identify, functional limitations, patient's perception of pain, contextual factors, and put it all together and determine what's best for that patient right there, because that
Right.
can't be captured, in these when we look at the evidence synthesis from a systematic review or a
Yeah.
meta-analysis or even a randomized controlled trial. So, it's a balance. It's a balance of the evidence of literature and the evidence of the patient. We respect to the evidence that's there, but we also have to pay respect to the fact that sometimes evidence emerges over time.
Mm.
Back when Dick Earhart taught us a sacroiliac joint course during our residency, he did a gapping technique for the sacroiliac joint and described it as being effective for treating many different diagnoses related to the SI. And he showed us this one technique that was a gap. Some people wanted to learn, a number of SI
Mm.
techniques. Said that's one, that's good. I'm good about that. If we have one go-to, and he said it's more important that we get a joint to move.
Correct.
And actually, years later, that same technique, which was described as a gap for the sacroiliac joint, became the technique lumbopelvic thrust that was in Flynn's
Mm.
study of the clinical prediction rule for lumbar manipulation. So, the technique he was demonstrating back in the 80s and 90s and
Mm.
teaching ended up being, you know, part of our
Implemented in practice.
you
Yeah.
know, development of a clinical prediction rule. So, we can't be dismissive of things, especially when they come from expert clinicians who've seen thousands and patients over many years, and it works. But then when they disseminate the information to people like Julie Fritz, who was at the University of Pittsburgh,
Mhm.
Dick Earhart was there, and Julie Fritz helped influence the development of that clinical prediction rule. Then we give respect to those that were really providing evidence of those patients they were seeing.
Yeah, I
Yeah.
love that, Ron. I think it's really important. I'm glad you talked about that scoping review because I had a couple, thoughts and questions and things. But well, I think it's important to go back to what you said about variability and not having that like common taxonomy and shared understanding. It may seem like a silly parallel, but it's like being in a relationship, right? If you're not speaking the same language, your understanding of what the other person is saying to you is going to vary. And not to mention the impact that could have clinically on our patients who are hearing something completely different from a provider who maybe shares the credentials. Like it can be, and I think this applies not just to directional preference, obviously, and the variability in defining it, but to manual therapy itself and OMPT, which has lacked that common taxonomy. Chad talked about this in the article a couple years ago. I think it was 21, where manual therapy has just been demonized and just sort of tossed to the wayside. And he's kind of advocating that we define it by its evidence-based function versus that one technique, like the Chicago roll or whatever the case may be. This is the definition has to encompass all of the things, not just the techniques, but also the clinical effects and the outcomes. So, I mean, what are your thoughts around like why is directional preference so hard to define?
Yeah, I think I touched on a little bit earlier in that
Mhm.
it's not understood to be a lasting change, and it's sometimes thought of as, someone that's got low back pain and peripheral symptoms. They do extension and lying or standing lumbar extension, and it centralizes or it doesn't centralize.
Mhm.
Then we move on to something else, as
Right.
opposed to looking at weight bearing versus non-weight bearing movements, not just in the sagittal plane, but the transverse plane, in a combination of transverse and so forth. And you also mentioned, kind of the language issues we have.
Mhm.
So, when I was in our manual therapy residency, we were taught a posterior to anterior central vertebral pressure, thought to be having an effect on the zygopopliteal joints potentially. And then later on in MDT training, we were taught a lumbar extension mobilization, the identical hand placement, location, and we're moving, at that time, it was thought to be moving the disc. So
Mm.
we're moving away from pathoanatomical diagnoses, which I think are good, but we're moving more towards classifications based on movements and responses to movement. I think MDT fits in well with that.
Mm.
We, though, shouldn't lose sight of those pathoanatomical diagnoses because um, they may be very helpful in us establishing parameters. So we wouldn't treat disc pathology if we hypothesize it to be disc generated the same way we would treat a muscle that's
Mhm.
weak or a power deficit. So there's a balance too between uh, the pathoanatomical diagnoses and the uh,
Movement based.
movement-based diagnoses. And like, unfortunately, many times in our profession, it's got to be one or the other, right?
Hmm.
Got to be one. Oh, I'm pathoanatomical or I'm movement-based. You need really to understand both. And
Hmm.
understanding, though, that we don't always know the pain generator. But
Right.
if we have an appreciation of how that person moves, and then we may establish a parameter that's quite different. If it's ligamentous, it may be 1,000 reps. If it's
Mm.
muscle, it may be, 3 sets of 10 every other day. And when I got out of school, everyone got 3 sets of 10, regardless of the diagnosis. So uh,
Right.
we have some challenges with language,
Yeah.
as you touched on, and we need to work towards more commonalities rather than pointing out
Yeah.
differences and discrepancies. And that's a job. That's
Yeah.
not easy.
Well, it's a big job, and I think the scoping review is really starting to probe that a bit. It's there seems to be this conflation of the two terms, centralization and directional preference, which you're highlighting, and not just what the scoping review found, but a lot of other studies kind of use them interchangeably, and I think I think because of my training with, Tim and Peter, it's clear that there's a difference, right? And I think if you think about the fact that there are those of us who are in training programs, fellowship training programs, and treating patients, like, we need clarification of those two terms, because the impact that this could have on those of us as clinicians, but also on our patients. I think you already kind of touched on the difference between the two, but I just want to highlight that, we talk about taxonomy and common taxonomy. It's not just words on paper or in research. The clinical application of these mechanisms, both powerful, but distinct, it has a direct impact on clinicians who are trying to learn, clinicians who are now in academia trying to teach, but then of course the patient at the center of all of it. So I just want to underscore how important what you're saying is, and to also maybe invite the listener to understand that we're talking about directional preference and OMPT and centralization, but this applies to many things in physical therapy. So I just really appreciate that conversation, Ron. What are your thoughts on the scoping review?
Yeah,
What There's a lot in there. Where are you going with this next,
yeah,
Ron?
yeah. So I think, as was done by Halliday, we need to look at those that operationally define directional preference, and those that didn't give a very clear definition of directional preference, and look at the difference in outcomes in those
Mm,
studies. So that's the next step with that. And also, one of our fellows in training recently graduated. I think he'll be recognized this October, or in November at AOMP, is going to look at, and Chad Cook's his advisor, look at one of his advisors, look at the mechanisms behind why directional preference may work. So we have these theories, and Rob McKenzie originally had this disc theory, but he, right from the get-go, said this is a theoretical model. It
mhm.
may apply, but it may not apply. And I heard him say before his passing at a conference, I wish I had named this approach, we're going to move people in the directions that make them feel better and avoid those that make them feel worse, at least initially. But that had been too long of a name approach. But he thought of it as being an evolving definition.
Mhm.
So he originally described it as movement of symptoms from a more distal to more central location. When we proposed development of a McKenzie Fellowship, he was very supportive of that, because he originally was a manipulative physiotherapist, and thought that maybe too many people had moved away from putting hands on. He
Mm,
said putting hands on is going to be necessary, and it's part of the MDT approach. So um, I think what we need to do next is see when you know these studies follow the operational definition. Does it
yeah.
make a difference in outcomes?
Yeah.
And it may not, we'll see, but that's the purpose of exploring that and looking at the mechanisms of why it works. So in our programs, our fellowship programs, we have the clinicians, the fellows in training, thoroughly understand when we bring a joint to end range what tissues are affected. So it's just not the disc, it is ligament, it's cartilage, it's muscle. And when a person goes to end range, things may change dramatically in terms of a baseline. And
Mm,
we know that with manipulation and mobilization, when we bring a joint to end range, people may demonstrate improvement. When a patient moves to end range, if they can move to end range, truly
mm,
move to end range, and are they a good candidate for end range testing is another question that hopefully is appreciated by the clinician in terms of safety. But there's tissues that are going to be stressed. And in our Damon Fellowship, we had 3 people who were in the program at the same time. Megan Donaldson was one of our fellows in training. Corey Simon, who is going to be a keynote at the upcoming conference, and Eric Miller. They studied together. But Corey put together a joint manual, which looked at the biomechanics, arthrokinematics, osteokinematics of all the joints from cranial to caudal, and what tissues are brought to end range when we bring a joint to end range. And that became our study manual for both programs, both the McKenzie program and the Damon program. And it still is today. So we thank him for that. He used that as a study guide. I asked him, if we could use it ongoing in the program. He said, of course. And we have a number of fellows in training who have to put in a considerable amount of study time just
mm.
learning that, and
Yeah.
as do most manual OMPT programs. So, but we want that to be integral so that we appreciate we when we bring a joint to end range or a person goes to end range, what's happening, and we
Hmm.
we can hypothesize. And Mackenzie had an original hypothesis, which he later expanded to extremity joints as well. So obviously, the disc model wouldn't work in the extremities, but we're seeing emerging evidence for testing end range with extremity conditions, and that is very interesting
Yeah.
uh, in terms of why, and how does that person improve. But it's all about baselines, rechecking a
Hmm.
baseline to see if there's a lasting improvement. And we can't just go by symptoms. So I think it's sometimes the MDT approach is misconstrued to be it's only about symptoms, and it's really
Hmm.
it's could be a change in mechanics, a myotome. But it's got to be a lasting change, a neural tension sign. You know, that
Ron,
right.
I think you're really we talked about bridging the gap. Everything you're saying sort of brings those two schools together. You when we were talking, we talked about how OMPT is also end range, right? Like joint manipulations are at end range. And I don't know if it's just something about repeated movements that people forget that we're talking primarily about end range, but I think that's an important thing that comment and phrase that sort of bridges the gap. And similarly, right, like even with OMPT and kind of your um, manual manipulative approach, it's we're also looking for lasting change, right? You don't look for a cavitation and go yay, as many of you know and many of us know. It's about the test retest. It's establish a baseline, apply your technique or techniques, and then retest. And when you phrase it like that, which is why I really wanted to have this conversation, because I knew that you, again, have bridged both worlds and still do, and can kind of help make sense of maybe where they seem so separate, but they're actually quite similar in the clinical application and the things we're looking for as far as the effect on the patient. So I really appreciate that, Ron.
Thank you. And there's mechanical effects that we propose
Right.
with manipulation and a person moving to end range, but we're seeing more and more evidence of the neurophysiological potential effect and even the placebo effect. And that's
Right.
if the person moves better and continues to move better, and it turns out it's placebo, that's not a bad thing.
Hmm.
Uh, but how that person's being approached is the difference maker in terms of whether that placebo may be achieved or occur. And that's if they're confident in their clinician, they have a good working relationship, they have shared goals in terms of the patient's outcome. And then when that clinician puts hands on in a confident and skilled manner, they're there, right?
Yeah.
They're there.
Yeah.
And then if they see a within session change in a baseline, they're really going to be there and buy in, so to speak.
Hmm.
So, the question is, can they treat themselves?
Hmm.
Do they require us to put hands on? Many do. Maybe we can move them along more quickly if we do. It
Hmm.
can be a combination of the two, but ultimately we want people to be able to be empowered and self-treat because we spend billions and billions of dollars on musculoskeletal healthcare and we just can't afford it anymore.
Yeah.
So we don't have enough evidence of this yet, but if the patients can become empowered to self-treat, maybe we can reduce recidivism and they don't
Yeah.
need to come back. But if we don't give them that opportunity to become empowered or take a role in their own uh, outcome, then they're going to be dependent on us. And I've made that mistake in my career, putting hands on too soon or in a patient who may have an external locus of control, and then
Mm.
it becomes very
Hard.
difficult. Even if we have a good working relationship, they become dependent on us. So I'd rather
Yeah.
educate that patient on how they could self-treat than me be the person that is supposedly making them better. We want them to make themselves better. That's
100%.
and that's why I believe so strongly in that uh, testing of sustained and repeated movements to see if that patient can use that as part of their management. But
Mhm.
then if we just test that and we don't test muscle balance, we don't test activation of deep spinal muscles, if we don't check for yellow flags, then we're going to miss out on something else that person needs. So it's just
Yeah.
not be about that. Uh,
Yeah. Yeah.
Patient-generated movement.
Yeah, it's gotta be comprehensive, Ron. I love that, and I think both approaches certainly take that on, and, as we're chatting, you just kind of keep adding to this bucket of this proverbial bucket that I have in my head that says, "Let's put all these things together that tie these approaches together," and obviously, self-efficacy is one of those. That's that's the end goal, right? It's you start with a therapeutic alliance. The name of the podcast is Hands On, Hands Off for a reason. So, I think you're speaking to a lot of the similarities and commonalities in even the approach, right? The execution may look different, but the approach in and the foundation is very similar, as well as what we're trying to achieve with our patients. But the self efficacy piece is one that I just want to underscore that you brought back into this conversation appropriately. So, Ron, I know you and we could probably go on and on and on and on, but I told you that I am interested in because you've done a lot as a clinician, as a faculty member, as a in higher education leadership and just fellowship and residency and all the things. You've done all the things, Ron. And one of the things that selfishly I want to highlight is your mentorship of some really incredible clinicians, researchers, thought leaders, innovators, Corey Simon, Megan Donaldson, Eric Miller, who taught my last two students in the clinic at DeUval. And so, it's kind of feel like we're kind of coming full circle where a lot of the folks that you've poured into, Ron, are pouring into our profession and OMPT in even more variable ways. What is the secret? What is your philosophy on mentorship? Why you're humble, so you will not appreciate me saying this way, but why are you such a great mentor, Ron Shank?
So I've had a lot of good mentors, and great leaders. Interestingly, the other day, Megan Donaldson, who's our AON president as well as our program director at the Medical University of South Carolina, where I am now, put out a something out for us to read as faculty on teaching and leadership. And I've always believed that effective teaching or mentorship is really about leadership.
Mm,
So and if you think about somebody that was an effective leader or a coach that you've had, it's someone who you have a trust in each other, a
mhm,
trust trusting relationship. They have a belief that we can be led or learn, take you on a learning journal, that you have respect and appreciation for what that student has done up
Mm,
to this point, and that they're willing to learn more. Um, and I was always amazed of these McKenzie diplomats who come in and, now they've learned something to the highest level. They want to learn more. I mean, that's quite an impressive compliment. But it's when you have that type of relationship with your students or those who you're mentoring, you end up supporting one another and then just kind of guiding each other along the next
mm,
step in their journey or in the mentor's journey. So um, I think really leadership
mm,
is tied into effective teaching, and when when you can establish that rate, it's kind of like patient care. When there's a
mm.
belief that you're going to be led in the right direction, then it just becomes a matter of keeping our minds open and learning from one another. So um, I think that those people who are good mentors or teachers, you know, tend to be good leaders as well.
Yeah, I love that, Ron. I love that so much. The first thing you said was that you had a great mentor. So, great mentors breed great mentors who breed great mentors. And I think obviously in the leadership of Megan, Corey, Eric, and others that you have mentored, there have been more leaders and this sort of generation of leaders, not just within AOMT, but in the profession. And I love the parallel to patient care. I think it is about trust. And something that you said that I really appreciate is that with your expertise and wealth of experience, you're still willing to learn from, your mentees. And I love that. When I was in the clinic and I was taking students, it was selfish. I wanted to learn from them. I knew they were getting the latest and the greatest from whatever program they were coming to me from. And I wanted that knowledge. And so it was a little bit selfish, my approach to mentorship. But I love that it's great to see the outcome of dedicated mentorship, not just clinical, but also professional development, and to see where all these great thought leaders are, thanks to some influence from you, Ron. So, and I know it goes both ways.
Oh, thanks.
Yeah. So, Ron, what's next for you in this space? Maybe in mentorship or in leadership? If I could put you on the spot, what are you working on?
Yeah.
Tell us more.
Yep. So, a few things. So, we have a research task force that explores studies on directional preference, and we have quite a large and emerging or growing group that's looking at that, and some are McKenzie trained, some aren't necessarily. So, we're open to people that are interested in kind of putting out ideas as we do, and then we go into breakout rooms and we work on particular projects, and so we meet quarterly, and that's been very fruitful, I think. Um, so and MUSC is very supportive of us, doing clinical research and um, having the ability and the freedom to balance both teaching and clinical work and clinical research is really critical, because if you take one element out,
Mhm,
it's tough. It's tough.
mhm,
Um, I think they all complement each other, and I was very fortunate to have worked for institutions that were always supportive of that. So, continuing to do research, clinical research. Once we complete our build out of this new program, I have an office here that I see patients, so I want to get back into doing more of that, and of course, you know, working with our students. So, Mo, fun and exciting that is to see them, begin to learn and begin that process, and uh, have them understand that this is just the starting point, right?
yeah.
DPT is just the starting point, and it's kind of what you do after you leave that makes the difference.
Mhm.
What greater compliment to an instructor than to see the people you've taught do very well, and that makes it all really worthwhile.
1,000%, Ron. Very well said. I have nothing to add. And I will continue to be inspired by your work and your leadership and hopefully be, a force of some good in this OMPT world, and sort of bridging gaps where gaps exist, and for the good of the profession and our academy. So this has been such a rich conversation, Ron. I've never had one that wasn't with you. So thank you for sharing your insights, your history, your journey, your experience. And for those listening, please, hit the subscribe button, stay tuned, share with your friends, your students, your colleagues, and we will see you next time. Thanks again, Ron.
Oh, thank you, Mo. Take care.
Thanks for listening to Hands On, Hands Off, the official podcast of AOMPT. Subscribe now so you never miss an episode, and connect with us at aompt.org or at AOMPT on social. Opinions are those of the guests and not official AOMPT policy. See you next time.